Hello, this is Dr. Paul Wang, Editor-in-Chief, Circulation, Arrhythmia, and Electrophysiology, and I'm delighted to introduce this webinar today, hosted by the Device Advisory Panel. I'm going to turn this over to Dr. Parik Sharma and Dr. Jordana Kron. Thank you so much.
Thank you, Paul. On behalf of CircANE and Dr. Paul Wang, our Editor-in-Chief, it's our distinct pleasure to welcome you to our webinar, Cardiac Neuromodulation and Heart Failure. I am Parik Sharma, Associate Professor and Section Chief of Cardiac Electrophysiology at Rush University Medical Center in Chicago. My co-host tonight is my friend and colleague, Dr. Jordana Kron, an electrophysiologist and an Associate Professor at the VCU Medical Center in Richmond, Virginia.
We are so excited to be here tonight with our fantastic panel of experts in this space. We're going to help educate us on cardiac neuromodulation in heart failure. So we want to encourage audience participation. So please feel free at any point to ask questions through the chat function. And there will be time after the speaker and during the panel discussion to ask questions. So please feel free to participate.
With that, let me go ahead and introduce our speaker, Dr. Vivek Reddy. I think he needs no introduction. Dr. Reddy is a professor of medicine at the Mount Sinai School of Medicine in New York. He's the director of the Cardiac Arrhythmia Services for the Mount Sinai Hospital and the Mount Sinai Health System. Dr. Reddy's pioneering clinical research has changed the way cardiac patients are treated. He's authored over 400 papers. Under his leadership, the Mount Sinai School of Medicine is the lead investigator in several multinational clinical trials, exploring new arrhythmia procedures and technologies. Thank you, Dr. Reddy, for being here. He will be presenting his data from a recently published article, Novel Neuromodulation Approach to Improve Left Ventricular Contractility in Heart Failure, a first-in-human proof-of-concept study, as well as some data on cardiac neuromodulation in atrial fibrillation. Dr. Reddy, the stage is all yours.
Thank you very much, Parik, as well. Thanks, Jordana. And I guess very importantly, thanks to Paul for accepting our manuscript. So I think with that, I'm just going to start sharing my slides here. Let me hide all the panels and there we go. So what I want to discuss today is cardiac neuromodulation in heart failure, and as well as in atrial fibrillation, to put this in context of other neuromodulation therapies. I do have lots of disclosures. The ones relevant for this presentation are listed here. Cardionomics, who's the company that supported the clinical trial that we published, and then some of the later work with Cardiacare that we're doing. So this is our manuscript, and I present this on behalf of my colleagues, Honza Petru, Philip Malek, Lee Stylos, Steve Gedege, and Peter Newsel. So by way of background, we should know that there are over 3.5 million admissions annually for acute decompensated heart failure in the US and Europe. And over the past 2 decades, outcomes really have not improved for hospitalized patients with decompensated heart failure. The current pharmacologic therapies that we have are either drugs like diuretics and vasodilators that fail to target contractility, or inotropes, which are limited by adverse effects because of the increase in heart rate, myocardial oxygen consumption, etc. So the hypothesis behind this study was that stimulation of cardiac nerves passing along the posterior surface of the right pulmonary artery may result in selective increase in ventricular contractility without increases in atrial rate, or in the heart rate in general, or increase in the risk for atrial arrhythmias. So the target patient population would be those who have a reduced ejection fraction, who get admitted because of heart failure. Of course, it doesn't necessarily make sense for patients who are responding well to IV diuresis, or who are in the other extreme of cardiogenic shock. And these are patients who have significant significantly poor outcomes. This is the anatomical target. What you're looking at here is the right dorsal lateral cardiac pulmonary nerve. And notice it passes posterior to the right pulmonary artery. So this is the main right pulmonary artery. It's anterior to the right pulmonary artery and posterior to the main pulmonary artery. This is sort of shows the progression leading up to this study and beyond. So there was initial preclinical research in the 1970s and early 2000s, as well as a preclinical study in Cleveland Clinic that suggested using a minimally invasive approach that could be important hemodynamic changes. These two are studies that were performed in, again, preclinically showing epivascular stimulation of this nerve can increase contractility as seen on these pressure volume loops. The baseline is in pink and stimulation is in blue. There are also improvements in echocardiographic parameters with endovascular stimulation, again, preclinical work. And that led to our 15-patient study. So the methodology that we used were the patients who were planned for CRT or ICD implantation, who had reduced ejection fraction, were sedated using propofol. They had 8 French introducers into the right femoral vein and the left femoral artery. Mylar catheters were placed in both the left ventricle and the root of the aorta in order to simultaneously assess LV DPDT as well as aortic pressure. And there was a stimulation catheter placed in the right pulmonary artery. And I should note, this stimulation catheter was not a dedicated catheter. It was an off-the-shelf basket catheter, this Constellation catheter. And as you see, we used a monophasic square wave pulse, 4 milliseconds duration, and variable amplitude up to a max of 20 hertz. There was a positive response, or we defined a positive response as a 5% increase in the ventricular DPDT. I should again note that this study was supported by Cardionomics. So again, just to show, we have the basket catheter in the right pulmonary artery. Then we would put 2 catheters, one in the LV and one in the aorta. Now, pressures to obtain simultaneously from all these various locations. This just shows we use the mapping system oftentimes to position this and select which electrode we want to stimulate from. And we'd go through different electrodes until we found an electrode that actually generated the expected response. There were a total of 15 heart failure patients with reduced ejection fraction who were enrolled, but ultimately 2 were not studied due to prior thoracic surgery and change in anatomy, and 3 were lost due to EP equipment failures and inability to stimulate. So ultimately, 10 patients were included. 6 male, 4 female, the mean age is shown. All were functional class 3 with a mean ejection fraction of 30%. 100% of the patients were on loop diuretics and 100% were on ACE inhibitors or ARBs. 90% of the patients were on beta blockers, half of which was carvedilol. And here's an example of the stimulation. So just to take you through this, on the top is heart rate. This is the max DPDT in the left ventricle, and this is the mean arterial pressure. So the red lines here represent a 20% increase, and you can see with stimulation at 8 and 16, 16 and 20 milliamps, you can see an increase in DPDT, as well as an increase in blood pressure. And this is over the course of 8 minutes. But probably more striking is this one. You know, one of the issues when we did the stimulation was the basket catheter, it was actually difficult to keep it in position, but we can take advantage of that. And so what you're looking at here is over the course of 35 minutes, during which stimulation was performed up to the 25-minute mark. And so again, this is mean arterial pressure, DPDT, and heart rate. With stimulation, you don't see much of a change in heart rate. Really, it stays about the same. But we see a significant increase in DPDT that starts really within a few seconds and really sort of peaks after a couple of minutes. And you have a commensurate increase in the mean arterial pressure. Now, again, as I said, there was difficulties with catheter positioning, and sometimes the catheter would move as shown here. When it would move, suddenly we had an acute loss of contractility, of the increase in contractility, acute decrease in mean arterial pressure. And then with some repositioning, it would slowly increase again. Again, we had catheter dislodgement and it dropped again. But you get an idea of a couple of things. One, with stimulation, you have an increase in DPDT without a substantial increase in heart rate. 2, that elevation seems to be sustained, at least over the course of a half an hour. We were limited in this trial to a total of 90 minutes for the full protocol. And most of the patients, we took less time than that. Let's just look at the overall results. So these are the aggregate data. If you look at DPDT max, so upstroke, there was a 23% increase, which is statistically significant. There was also a 14% increase in relaxation. So there were improvements in both inotropy and lusitropy. And this happened again without a substantial increase in heart rate. You see this 4% increase, which was neither clinically nor statistically significant. There were improvements in the mean arterial pressure, the systolic pressure, and the diastolic pressure. Note also that the LV systolic pressure did increase by 16 points, and that's an absolute increase of about 14 millimeters of mercury. The diastolic pressure increased by 32%, but this was neither clinically significant. You see this increase is only 0.3, nor was it statistically significant. And here you see the individual changes in DPDT. These are the 10 patients, and you can see the increase in DPDT from baseline to the max stimulation point. So based on this first-in-human study, we were able to demonstrate that LV contractility could be significantly increased without the change in heart rate in class 3 heart failure patients with stable hemodynamics. The contractility could occur in the presence of beta blockade. The effect was titratable, and the increase in contractility was sustainable over the duration of stimulation. And we also should note that stimulation did not induce arrhythmias. And our conclusion in this study was that if these observations are confirmed in hospitalized heart failure patients in a randomized fashion, it could be a promising new therapy for acute decompensated heart failure to help patients leave the hospital quicker. Where are we going from here? Well, the company has developed a dedicated catheter. So the catheter has several different aspects to it. One it has pressure sensors to give you RV as well as PA pressure. It's an over-the-wire system delivered through a dedicated system that allows for flushing. It has the ability with this nitinol braid to actually fix the catheter in the pulmonary artery over the duration of stimulation. And there are multiple electrodes that the operator can use to stimulate the nerve. And of course, it's an atraumatic tip to be able to navigate the curvature of the pulmonary artery. So this is the proof of concept study that we performed. There was a feasibility study and a mapping study that was also performed using commercial and purpose-built catheters, and these provided the basis to create this dedicated catheter system. Now there's a pilot study which has a 10-patient lead-in and a 40-patient randomized arm. And then ultimately there will be a pivotal study. The design will be informed by this pilot study. Just a few points about the pilot study. There are 15 sites in the US, Europe, and Latin America. Again, 40 patients will be randomized to treatment or control. This is obviously a randomized but unpowered pilot. There's no formal hypothesis testing. And if we look at this, there'll be safety assessments, performance assessments in terms of looking at changes in pressures and heart rate, changes in mixed venous oxygen saturation, changes in cardiac output, echo assessments, and changes in pressures throughout the therapy duration, which will be more than just 30 minutes. It'll be a couple of days. There are also medications will be assessed, changes in blood and urine labs, of course, patients' symptoms, hospital readmission rates, length of hospital stay, and echo assessments. So with that, I think that was our manuscript, and I think it's a very interesting electrical approach to facilitating the treatment of acute heart failure patients. So at this point, I want to spend the rest of the, let's say, 5 to 10 minutes talking about some other interesting neuromodulation approaches. And these are being applied for arrhythmias as well as heart failure. And there's 3 I'd like to address very quickly. One is renal denervation. The other is low-level tracheal stimulation, which is a type of surface stimulation to affect low-level vagal output. And then the third is a variation of surface stimulation called median nerve stimulation. So let's start with renal denervation. Let's start with some of the data after AF ablation. This is one of many retrospective analyses. And when you look at patients who undergo AF ablation, you look for what are the clinical predictors of recurrence. One of the most important, well, certainly there's duration of AFib, whether or not the patients are taking ACE inhibitors, ejection fraction. But one of the strongest is the presence of hypertension. Patients who have hypertension have a much higher incidence of recurrence after AF ablation. Based on this, there are several studies, this one colorfully named the SMAC-AF trial, which randomized patients who are undergoing AF ablation to either standard blood pressure treatment or aggressive blood pressure reduction. It was a 184-patient study, and sure enough, there was a decrease in blood pressure in the aggressive group in blue compared to the red group, the standard group. And this is over 12 months. However, no change in AF recurrence. Now, contrast that with this study. This is the moxonidine study, and again, an antihypertensive drug, an alpha-2 agonist. And here, again, patients who had AFib and hypertension who were planned for ablation received either placebo or moxonidine. They underwent catheter ablation. So the question was post-ablation recurrence. And what was seen was that moxonidine reduced recurrence by almost 50%. And interestingly, this occurred without a significant change in blood pressure. So how do we explain this? Hypertension predicts AF recurrence, but direct reduction of blood pressure didn't improve. On the other hand, an alpha-2 agonist did seem to improve outcomes. And it may be that we can reconcile this by looking not necessarily at the hydrostatic effect of these therapies, but the effect on sympathetic tone. So this is an interesting study. Patients undergoing PVI, underwent MIBG imaging. And what was really interesting is those patients that had high washout rate, indicative of sympathetic nervous system overactivity, had a much higher recurrence. So based on this, Evgeny Pakushlov, I think we have to really congratulate, along with Jonathan Steinberg and their colleagues, for really sort of pushing this along. And most recently, they published the Eradicate AF trial last year in JAMA. And what they saw was that compared to PVI alone, PVI plus renal denervation decreased recurrence by 43%. And this was a statistically significant result. This is a meta-analysis that we recently published, looking at 725 patients, including both Eradicate AF as well as a number of other studies. And what you see are, these are the differences in recurrence. That is, with the adjunctive renal denervation, there are 32% fewer patients with AF recurrence. Based on this, we're doing a trial called Ultra-HFib. It's an investigator-initiated IDE where we're taking patients who have atrial fibrillation and some degree of hypertension, controlled hypertension. And these patients, after ablation, are randomized to either denervation or no denervation. And here we're using this ultrasound catheter, which emits a circumferential ring of ultrasound energy, as well as it cools inside. So the idea is you have a thermal profile where you have cooling of the wall, but heating around this. So this is in clinical trials, and we'll have to see what the results show. Let's move on to low-level tracheal stimulation. We have to really thank, I think, Sonny Poe and his colleagues at the University of Oklahoma, who really have brought this idea of surface stimulation from some of the other fields in medicine to cardiology. They published a number of studies. Now, I'd encourage anyone who's interested to look over these studies. I'm going to talk about two of them that were very interesting. This was looking at, in a randomized fashion, low-level tracheal stimulation in post-op AFib patients. And what was seen is that compared to control patients who had a 40% incidence of post-op AFib over 20 days, low-level tracheal stimulation abrogated this substantially. And there are also improvements with low-level tracheal stimulation in terms of different inflammatory products and cytokines. What about, and then they published this study, and it's sort of the standard, let's call it organic atrial fibrillation. So first they did an acute study where, again, in a randomized fashion, they either performed low-level tracheal stimulation in blue or control in patients undergoing EP studies. What they saw was that in control, you had a decrease in atrial ERP with stimulation, but with low-level vagal stimulation in the tragus, you did not have this decrease in atrial ERP. There was also an increase in AF cycle length with tragus stimulation, and this was accompanied by significant decreases in TNF alpha and CRP. Again, this is all acute; these are all acute studies. And they followed this up with a chronic study called Treat AF, where they randomized patients who had paroxysmal AFib to either stimulation or placebo, which basically they had them stimulated in a different location, the earlobe, which didn't have an effect. Compared to the control group in red, where there was an increase in the amount of AFib over time, with the active group, it actually decreased, and this was highly statistically significant. If we look at AF burden compared to taking baseline versus 6 months, in the active group, it decreased substantially compared to the control group. If we look at cytokine levels, there was a significant decrease in TNF alpha, but not really in the other interleukins. If we do a responder analysis, it was interesting that, and where we define, or they define response as a decrease in AF burden by at least 75%. What was seen is that in the control group, there was only one patient that responded. So basically a 5% response rate. In the active group, it was a 50% response. So half the patients had a response and the other half did not. Unfortunately, they were not able to identify a clinical predictor of response. And so this is an area of further research. Though they did do some sub-study sub-studies that have recently been published looking at neuropeptide Y, which may be a predictor of response to low-level tracheal stimulation. And finally, in the last 2 minutes, let me just go over another novel target, median nerve stimulation. So the idea is here, the median nerve in the wrist. This is a preclinical study, a canine pacing model of atrial fibrillation. And in this particular study, they either did a sham operation or median nerve stimulation. And they did pacing in all animals. And whether you look at the right atrium, right atrial appendage, left atrial appendage, or left atrium, what you see is in the sham operated group, so no median nerve stimulation. With atrial pacing, you have a decrease in atrial ARP, and that's sort of expected, right? But with median nerve stimulation, atrial pacing did not cause a decrease in atrial ARP. Similarly, if we look at inducibility of AF, what you see is in the control group over 3 hours, you have an increase in inducibility AF, and that was largely abrogated by median nerve stimulation. And if you look at inflammatory markers, again, similar things. Compared to control, with in the sham group, you have an increase in TNF-alpha and IL-6, but this is completely eliminated with median nerve stimulation. So that's a preclinical study. What about clinical data? Well, we actually can glean some of this from acupuncture. It turns out that electroacupuncture at the so-called Negrian point is actually affecting the median nerve. And this is a really interesting paper that I completely missed. It was published a couple of years ago. The investigators took patients with persistent AFib who were planned for AF ablation and randomized them after ablation to either amio or amio plus 7 days of acupuncture. Now, this was not a blinded study, but it is a randomized study. And they were looking at this sort of early post-ablation AFib. And what they saw was that compared to amio alone in red, the acupuncture group actually had a substantial decrease in this sort of early post-ablation AF. It went from 33% to 12%. That's almost a 70% decrease in AF recurrence. Now this is only acutely. Of course, one would be really interested to know what happens if we follow these patients out further. There's also commensurate changes in TNF-alpha and IL-6 in the control group compared to pre-procedure. There's an increase in these markers that then decreased at 3 months. With the acupuncture group, there was no such increase. Again, with only 7 days of acupuncture immediately post-ablation. How can we take this to the next level? Well, there's a company called Cardiacare, which is developing basically a wristwatch-like device that has these electrodes to do median nerve stimulation. And the idea is to perform median nerve stimulation to restore this autonomic nervous system balance. This is just, there's very little data, but I'm just going to show you an example. 67-year-old male with multiple PACs before a single treatment and after treatment, no PACs. Here, if you look at in 140 treatments, 28 patients, if you look at the mean PACs in before versus after, there's a 62% change. Again, each patient compared to themselves. And interestingly, there are also significant decreases in PVCs, which raises some other interesting questions. What about AF recurrence? There's not much data, but there is an open label study that the company conducted where they took patients who are undergoing cardioversion, performed median nerve stimulation, which you see here, the recurrence of AFib compared to historical control. Now, all of us know the number of potential confounders here, but this is just an interesting initial study. The question, of course, whether you're thinking about this or any other sort of neuromodulation, is when would you intervene? Would you think about intervening so early in terms of patients who have a high degree of PACs, who we know many of which will go to paroxysmal AFib? Do you intervene at the time of paroxysmal AFib, maybe before drugs? Do you do this at the same time as catheter ablation, maybe to prevent post-ablation, the early post-ablation as well as the late? Or perhaps in those patients that we do an ablation who have those sort of short atrial arrhythmias that we sort of ignore because we can't do anything about them, but certainly can bother patients. I think these are different areas that one could certainly consider. The major point I want to make is that this idea of surface stimulation, and this is a tragus stimulation, but even other approaches, is really being studied in cardiology, in neurology, pain, psychiatry, and lots of different spaces. And I think it's something that we as electrophysiologists should become familiar with, because I think we are going to see this in clinical practice in the not too distant future. Thank you.
Thank you so much, Vivek. That was a fantastic rundown of some of the cardiac neuromodulation approaches we have, not just for heart failure, but also with atrial fibrillation. I think let's start with a couple of quick questions pertaining to your study before we open it up to the panel to discuss this broad topic. So one interesting thing that crossed my mind was, this is certainly a novel approach of stimulating the epicardial nerves behind the right pulmonary artery. And it seems to have an impact in the acute phase of heart failure, decompensated heart failure based on that small patient cohort, which is very interesting. Do you think there's a potential role for this that you see in the long term? Because our bigger challenge is, of course, not just trying to get these patients to a compensated state while they're hospitalized, but also trying to figure out ways to keep them out of the hospital. Do you think there's some role in this sort of a therapy when we look at that?
No, it's a great question, obviously. Look, the company has focused on acute decompensated heart failure for a couple of reasons, one of which being the absence of really good therapies in this population. It really is a population with clinical need. Now, having said that, I completely appreciate what you're saying. Just from a technical perspective, it's not a trivial issue, right? You don't want to keep this catheter with all of the structure inside. So you'd either have to go with an approach where you would have a screw-in type of lead that goes slowly through the pulmonary artery to the epicardial surface to pace, which again, in the myocardium is one thing. In the pulmonary artery, I just don't have enough experience to know how safe that would be. Or you go to a pericardial approach and go from the pericardial surface and put something there doing directional stimulation. So I think those are interesting ideas. I don't know that anybody's actually pursuing them yet, but that just means that I don't know. I'm sure somebody is.
Dr.
Or you
Reddy,
can have an expandable stent with stimulators on it that can be remotely controlled and just a really out of the box idea.
Yeah,
Dr. Reddy, I have the question for you. How is this tolerated? The patients during this small cohort were sedated, and it was a short time period. So both for this study and then maybe also for the median nerve stimulator, can patients be awake and tolerating this? And even with the median nerve stimulator, does that bother people after a while? Can they sleep with that? Do they sense that? And does it bother people after it's on for a while?
Yeah, great question. So let's talk about this study. So in our study, you're absolutely right. We did sedation. Our goal here was really to understand if it was even possible, because it wasn't clear whether or not this could be done. And in fact, in some of the patients, I didn't have time to talk about it. In 5 of the patients, they did actually have coughing, but the coughing occurred at locations that were not the area of proper stimulation. Okay, so when you get to the proper stage, at least in our N of 10, you want N of 1,000 eventually, but in our N of 10, we did not see anything in our sedated patients. But really, this is one of the goals of the randomized study, right? Of the pilot randomized, to really make sure that people can tolerate, both in terms of tolerating, as well as in terms of being able to tolerate for overnight. I mean, doing an hour of stimulation is not going to be sufficient. You want to be able to do it while they're in the hospital to get them out of the hospital and improve things. Now, with regards to surface stimulation, and this is true for both tragus stimulation and median nerve stimulation. Now, I have no personal experience with tragus stimulation, but I talked to Sunny, and actually that's not true. One of my patients, I was able to get one of those stimulators from Europe, and he's using it, but it seems to be well tolerated. And I just want to emphasize, this is not continuous stimulation. So the stimulation is usually for about, we asked our patients to do it for half an hour, an hour, which is what they did in the TREAT AF study, once a day. With the median nerve stimulator, again, same thing. So it'll be about an hour stimulation, a couple of times a week, 2 to 3 times a week. So that's the protocol that seems to be good. Patients seem to tolerate it. It's not painful. It just feels like something warm or a vibration-like feeling. So, in fact, I didn't have time to show, but there was a small study of 30 patients where the device was used in normal volunteers just to understand tolerance. So I don't think that's going to be a major issue. I should also note, this idea of surface stimulation, whether it's tragus or other areas, this is being used outside of cardiology, right? So it's being studied in things like a seizure disorder. In fact, I think it has FDA approval for seizure disorder, tragus stimulation, that is. So there is a large literature that none of us know about that of using this in patients. So the safety, I don't think is going to be the issue. The interesting question is the efficacy, because I am sure that you change the parameters a little bit, you change the protocol a little bit, and you probably won't have as good efficacy as otherwise. So that needs to be teased out.
Congratulations on this study. It's so exciting. It's really a proof of concept, right? First human proof of concept that you can do this and that you can increase the contractility without having these negative consequences like increased pressure and increased heart rate. So, but it opens all these other questions because it's so exciting.
Thank you.
Well, thanks, Vivek. I think we'll move on to invite the rest of our panel over this last half hour just to have input from some of the experts in this field. So we have a fantastic group of expert panels. First up, we have Dr. Mirnela Byku. Dr. Byku joins us from the University of North Carolina, where she's an assistant professor specializing in heart failure. She trained at the St. Louis University and did her residency at Johns Hopkins. She's received a PhD from St. Louis University and an MBA from the Dowling College. She's published in neuromodulation and heart failure and was on the writing committee for the AHA scientific statement on heart failure in the era of prescription medicine. We welcome you, Dr. Byku.
Thank you very much for having me. Very exciting.
I am also delighted to welcome Dr. Michael Gold. Dr. Gold received a PhD in physiology from the University of Virginia and an MD from the University of Colorado. His postgraduate training and fellowships in medicine, cardiology, and EP were at Mass General and Harvard Medical School. And in 2002, he moved to Charleston, South Carolina, where he assumed the role of Chief of Cardiology and the Michael E. Assay Professor of Medicine and the Medical Director of the Heart and Vascular Center at the Medical University of South Carolina. He is a past president of Heart Rhythm Society and has authored more than 270 peer-reviewed publications and more than 30 book chapters and reviews. He's an international speaker on all types of EP-related topics, and he's a pioneer in the development of new defibrillation and pacing techniques. We're very delighted to have you here with us tonight, Dr. Gold.
Thank you very much. Pleasure to be here.
All right, next on our panel is Dr. Kamala Tamirisa. Dr. Tamirisa completed her internal medicine training and chief residency at the St. Louis University in Missouri. She completed general cardiology, cardiac electrophysiology, and also has a cardiac MRI fellowship that she completed at the University of Michigan in Ann Arbor. She served as the director of the Arrhythmia service line for ProMedica HVI, ProMedica Heart Institute board member, and the Heart Institute EP Council member. She serves in the HRS Digital Health Committee and the HRS TV Subcommittee. Her special interests in cardiac electrophysiology include leadless technology, novel and adjunct therapies in heart failure, arrhythmias in pregnancy, and disparities in AFib. It's a pleasure to have you with us tonight as well, Dr. Tamirisa.
Thank you so much. It's an absolute pleasure to be on this wonderful panel. Look forward to more discussion. Thank you.
And last, but certainly not least, is Dr. Jagmeet Singh, who joins us from Harvard Medical School. He has an MD, PhD, and is the founding director of Resynchronization and Advanced Cardiac Therapeutics program there. He's a national and global principal investigator on 5 ongoing multi-center clinical trials in device therapy for heart failure and catheter ablation for atrial fibrillation. Dr. Singh, thank you so much for joining us tonight. We're so excited to have you here with us.
It's a pleasure to be here.
All right, so you know, I'm gonna open this up with a question that is fairly broad. So you know, I would like for each and every one of the panel members to sort of share their thoughts. When we think of cardiac neuromodulation for heart failure or atrial fibrillation, there are 3 broad categories. One is cardiac contractility modulation, baroreceptor stimulation therapies, and phrenic nerve stimulation. And these have all emerged in different studies as potential promising approaches with different subsets of patients with heart failure. So we'd like to hear from each of the panel members on their thoughts of what do you think amongst these categories, which areas do you think has the most promise in certain subcategories based on your experiences and studies that each one of you may have participated in or published in the past?
Could I go ahead and take that? You know, with the cardiac contractility modulation, that's the one I've been doing. And I think the future, the main problem has been, it's limited to Medicare patients, not to private insurance patients. And then the second thing, I'm looking forward to their integration of the CCM with the defibrillator therapy. Because right now, if someone has an ICD, putting leads on the other side, convincing patients to get more and more leads, a risk of infections and complications has been a main barrier, and that's a real barrier. And the baroreceptor stimulation, I think, has a wonderful role in lower ejection fraction, windows less than 25%, and CCM, I would say, is more towards higher EF. Those are my comments, and let's see what the other experts have to say.
I'll follow with that. I won't speak on the AFib side of things, but as far as heart failure goes, I'm going to play devil's advocate here and be a true heart failure doctor. And I have my cautioning statement in general when it comes to heart failure therapy is that we should always be very aggressive with medical therapy. And this is an extremely exciting area and an extremely exciting time in this area in heart failure in particular, because not only there's therapies for advanced heart failure, which is a completely different beast, so to speak, but there's so much development and so much news and excitement on bread and butter heart failure. So for years we only had ACE inhibitors and beta blockers, and that is, as you could tell from the study, the listed medications were diuretic, ACE inhibitor, beta blocker. There was no mention of spironolactone, there was no mention of Entresto, there was no mention of SGLT2 inhibitors, which are all new and improved, so to speak, drugs. And the trials on Entresto and SGLT2 inhibitors are also tremendous, because when you compare them with the original trials on beta blockers, the only therapy that you had before beta blockers were ACE inhibitors, and before ACE inhibitors, you had nothing. So to show mortality benefit and morbidity benefit with Entresto and SGLT2 inhibitors was very hard. The studies were very rigorous. The follow-up was very rigorous. The N required and the N of patients studied was much higher. So I guess what I want to say is that when you combine neuromodulation therapy with appropriate medical therapy, it becomes an extremely exciting and a whole game changer for patients. What we do need to do, I feel like in this field, is to do what we did with MitraClip. So have a very close collaboration between electrophysiologists and heart failure doctors, so that when we are putting these devices in, we have already made sure that we cross all the T's and dotted all the I's, and we have absolutely maximized medical therapy, and then we've made the appropriate patient selection so that we don't have a confusing picture. That's all I'll say about that.
So if I could take the liberty of going next, so hear me out for two seconds. So first, I'm going to answer your question directly, Parik, about CCM, baroreceptor, and what was the third technology? You said phrenic nerve stimulation. And then I'll talk about the other therapies. So first of all, I don't think CCM is as much of an autonomic modulating therapy. It basically involves high voltage impulses in the midst of the QRS that causes sarcolemmal calcium release that then translates into increased contractility. As Kamala said, it is better used in patients with a higher ejection fraction because you need electrotonic continuity between the cardiac myocytes. So people with a EF of 25% and higher tend to do better in these patients. That's one. So I'm not sure we can call it neuromodulatory. Number two, phrenic nerve stimulation is a therapy used for central sleep apnea in patients with heart failure. Again, specifically targeting the phrenic nerve. Not sure how much of autonomic modulation it has, besides probably impacting sleep indirectly. So again, something we've seen, we've worked with, works well for central sleep apnea. And it's different from the SERVE-HF study where they actually use ventilators with positive pressure ventilation, where they had a higher mortality. this is different, clearly affects the apnea-hypopnea index favorably. Thirdly, baroreceptor, yes, that is certainly a modality for autonomic modulation. Certainly has significant swings in the heart rate, blood pressure, and contractility in patients, and has been shown through the BEAT-HF study and a couple of other studies to actually impact reverse remodeling, long-term outcomes, as well as symptomatic improvement in heart failure patients. There are many other neuromodulation therapies that we've not talked about. Some of them, which obviously is the vagal nerve stimulation, we know, which Micheal was the overall national or international PI for the Innovate-HF, and I'm sure he'll add to that, is another study that is, although vagus nerve was neutral to not positive in that study, it's still being investigated in the Anthem-HFrEF study to see if stimulation with a certain biphasic stimulation protocol, as Vivek alluded to, with a certain frequency, can change the stimulation of certain A, B, or C fibers in a different way that can actually modulate the sympathovagal balance that can be favorable. We know spinal cord stimulation did not work from the DEFEAT-HF trial. Renal denervation, as excited as Vivek is about it, I have some reservations about it in terms of selecting the right patients, dosing it appropriately, and then having targets for how you actually measure outcomes in these patients by modulating the sympathovagal balance in these patients. So that's another modality. And then obviously the cardioneural plexi in between the aorta and the pulmonary artery that Vivek is stimulating and has shown to really have important impacts, I think is the next strategy, whether one can make it into a durable, relatively non-invasive, sustained strategy. It remains to be seen. Lots of more exciting things to say, but I'll stay silent after this and come back and join the discussion.
Well, I guess I'll drive the caboose and be last one up, but it's actually nostalgic listening to Vivek's presentation, and I'll take people back just a little bit, actually probably a lot bit for some people, but when we first started doing pacing for heart failure, the first studies were short AV delay, right ventricular pacing, which turned out to not be real, as best we could tell. We got involved very early, 25 plus years ago, doing this, and our first model was post-op CABG patients, where we had our surgeons putting epicardial leads on the left ventricle and the right ventricle, not in heart failure patients, in standard CABG patients who were all instrumented post-op, and we were pacing. And what we found and published was that pacing the left ventricle increased hemodynamic function. Cardiac index went up with that. And we got really excited about this. Let's do this in heart failure. So we then started implanting devices with no CRT, no coronary sinus. Again, sort of crazy stuff of having our surgeons put epicardial leads on the left ventricle in a pacemaker in heart failure patients. No idea about desynchrony or anything else. So these were low EF patients, not with short QR, not with long QRSs, and basically it was a bust. We couldn't find anything. And there were two centers. I was doing it when I was in Baltimore, University of Maryland, and the folks in Utrecht, Netherlands, Patricia Bakker were doing them. And they had a couple of patients who dramatically improved. And we scratched our heads and said, what's going on here? And it turns out the ones who improved had a left bundle branch block. We had no idea about electrical dysynchrony or anything at the time. And all of a sudden we got interested and others got interested about cardiac resynchronization therapy, which is an indirect process that we use. Both conduction system pacing, which we're excited about now, as well as CRT, is not direct autonomic modulation, but we're basically improving dysynchrony, and therefore we see norepinephrine levels decreasing and everything that we'd like to see in terms of improving function of the heart. And we're now sort of coming full circle again with multiple different modalities, as Jag sort of very elegantly described, different ways of directly trying to do neuromodulation. I got involved with vagal nerve stimulation. Doug Mann and I sort of ran this truly remarkable. I think this was a small startup company in Israel with about 20 employees, and we did a 700 patient, worldwide randomized trial of vagal nerve stimulation. Unfortunately, at the time, while we're all excited about it and all the preclinical stuff looked good, we didn't really know, how do you stimulate the vagus appropriately? What's your duty cycle? You can't just continuously stimulate a nerve because the nerve will die from that. How much do you stimulate? What energy do you use? How do you know you're actually getting effect directly on the heart? And what we showed was that, patients felt better who got this, patients had better quality of life indices who got this, but we could not show by following them out in time that actually the hard endpoints of heart failure or mortality improved. So the primary endpoint turned out to be negative. It was a startup company. Within 10 days of reporting our data, the company was defunct and no longer existed, and nothing further happened from it. So, a very interesting experience, but it shows how complicated the brain and nerve was, and nerves are compared to stimulating the heart, which is a much simpler thing to do. The baroreceptor stuff, and for full disclosure, Jag and I are both on the steering committee with CVRX for BDHF stuff, and it's very encouraging data. It's similar in many ways to Innovate HF, that we don't have mortality and morbidity heart failure data yet, where that's being accumulated, and the FDA has been much more supportive of getting that, but hopefully that'll work. But neuromodulation is tricky business. How do you stimulate the spinal cord? What do you do with renal denervation? Because the nervous system is afferent, it's efferent, all sorts of different inputs. We have a long way to go, but it's a great, exciting field. So I remain cautiously optimistic that we're going to hit a home run with one of these. So I hope that Vivek's study will give us an acute therapy, and I hope that baroreceptors or something else will give us a more long-term durable therapy for this.
Can I ask a quick question, Vivek? So what is the mechanism for pulmonary artery stimulation for increasing myocardial contractility without changing the heart rate? I mean, if one is going to use an autonomic explanation for a shift in the sympathovagal balance, then you would expect some change in the heart rate, either through the sympathetic axis or either through the vagal axis. Is there something at the molecular level or directly at the myocyte level that you think is happening?
No, it's a good question, Jag. So it actually is at the anatomic level. And what I mean by that is, so for example, if you do the same sort of stimulation higher up at the stellate, for example, you will see increases in contractility, but you also see increases in heart rate, myocardial oxygen consumption, et cetera. Okay, so that's not favorable. But the idea here is that by stimulating lower, where after the sympathetic fibers, because at this point, that right sympathetic fiber is passing the pulmonary artery, and based on very detailed cadaveric studies, it goes then to the ventricle. So you already passed the SA node, and unlike what we see in the atro-periganglia plexi, where there's huge interconnections, I don't know if the interconnections are less or what it is, but we don't see that. And that was one of the questions, of course, is do you see a change in heart rate? And that was pretty clear that we saw minimal increase in heart rate.
And we saw the same thing in a much smaller study, but our initial studies of simply pacing the left ventricle with epicardial pacemakers, we assume in retrospect that we were simply activating sympathetic ganglia on the ventricle. So you don't get the other aspects of things. All you get was more of a increase in contractility without affecting the rest of the true autonomic balance.
The biggest problem out here, I think, is if you look at the neuro cardiac anatomy, they say the heart has a small brain which is fixed with multiple ganglia, almost I think in the millions, which are interdigitated, connected, and they're constantly relearning how to function. So even when you modulate the autonomic tone in a specific way, the system kind of relearns to rejigger, and after some time, it adapts to it and changes its functionality, and then you may not have the effect that you had when you started off. And so my question also is, when we enhance cardiac contractility, for example, using heart failure drugs, through increased contractility, there should be a shift in the sympathovagal balance, because now the autonomic input and output has changed through increased contractility. So there should be some subsequent change in heart rate, even if it's delayed and not acute. There should be some accompanying change in heart rate with any change in contractility. So it's really interesting that if you stimulate at a certain level below, that you don't have this feedback loop mechanism.
Yeah, I mean, look, again, just one really sort of quick point. A strength of our study was the fact that we did look at all of this. A significant weakness of our study was that we looked at it over the course of 60 to 90 minutes. Okay, so that's the importance of the pilot study. Well, one of many importances, which is to look at the duration of effect at least over the course of a couple of days.
Yeah, I was going to add that I'm not sure that that's a question that I have actually for the studies. I'm wondering what the hemodynamic profile of these 10 patients was, as far as, you know, were they low output? Were they, you know, normal preserved output, etc.? Because we see this also with anatropy. You know, when we use it in patients, they'll feel okay, like everything improves for a little bit, and then everything deteriorates again, you know, shortly after, and you kind of almost expose the true cardiac dysfunction. So it would be really interesting to see how this therapy plays out in for a longer duration of time, if it does the same thing or not as anatropes, if there's that negative compensatory portion of it, so to speak. I think the encouraging part is that you did have this increase in blood pressure without the increase in heart rate, which is very reassuring, and hopefully there'll be something that plays out with a longer duration of the therapy.
Yeah, I should note, and this is an important point, the population we studied, again, were heart failure patients and not just random, you know, patients who are undergoing EP studies. But the flip side is, while they were class 3 patients who were indicated for IV pacing or ICD, these are not decompensated heart failure patients, right? So you're absolutely right. We just don't know how those patients react. Again, that's one of the important questions in these forthcoming studies.
So Parik,
Just wanted to, sorry, Jag. No, just wanted to comment on this. Just what are your thoughts? You think the future would be something like, you know, CardioMEMS integrated with this, so you can measure the numbers? And second comment is, it would be very interesting to see that, you know, if we can even slow down the progression of heart failure to LVADs and transplants and, you know, progression without doing inotropes, if we can use this as a bridge to get our patients to heart transplant. Just comments, what do you think of that?
Well, again, I just want to stress that the way this is set up, the next catheter, the dedicated catheter, does have the ability to check various pressures, whether it's PA pressures, et cetera. So I think that the interaction with things like CardioMEMS and other such devices that are being developed, I mean, I think one is an acute therapy, the other is a chronic monitoring therapy. So I don't see the interaction, at least in its current embodiment. I mean, but again, if it becomes what Parik was suggesting, then obviously everything changes. You know, one interesting thing is this is really a complicated space. And I'm not talking so much about acute, but the chronic heart failure. There are so many therapies. I don't know what to use, to be honest with you. There's so many that are coming down the pike. They were all going to
all of them. All of them. You got to use them all, just very slowly. Right, and methodically. That's right.
No, but that's it. I completely agree with you. From a very practical perspective of clinical trials, because I agree all these should be studied in large trials. These are nightmare trials, as I'm sure you know. Heart failure, systolic, HFrEF trials now are a nightmare. And part of it is that it's not, I think we're still learning, and I mean, all of us are learning how to titrate therapies up quickly in heart failure patients to maximum tolerated doses, so that you can actually enroll patients. You can identify who still needs something and who doesn't. But I could tell you, I mean, I'm involved in a couple of these heart rate trials. It used to be the hypertension trials are the worst trials to be involved with. I think that's now changed to heart failure.
Well,
but this therapy may be a acute therapy. I mean, yeah. It's not clear that this is going to be a chronic therapy. This may be a decompensated heart failure patient. It's a bailout. It's an, you know, intensive care unit bailout therapy, you know, to avoid some of the negative aspects of inotropy or high dose inotropy, which would be very important if we could do
or
that.
It may even be an adjunct. I mean, I have to say that I'm an advanced heart failure doctor, and that's what I do every day, you know. sometimes you have people on 1 or 2 inotropes and their heart rate is going up, and you're kind of waiting to finish evaluation or to waiting for a transplant or whatever it is, and having another tool in your toolbox kit, so to speak, is very, very helpful for us that might not have as deleterious effects on raising their heart rate. But heart failure, again, I'm excited about it because I'm a heart failure doctor, but I do think that the key is that you don't want to uptitrate medical therapy very quickly, which is what makes it harder in a clinical trial, because you can't. If you do it quickly, they're not going to tolerate it, and then they're going to not be, they're not going to be part of it. You have to do it slowly. It's going to take you seeing them every 2 weeks or so and going slow on it, and then you'll see how much better they tolerate it. And it's just the way it is. But
That's
it's hard. I agree.
Yeah, hence the challenge.
So Parik, you mentioned about an implantable stent with electrodes and stimulation. It's not too far from the truth, because there's a company called Inopace that actually has an implantable stent in the aorta that goes right over the baroreceptors, and a handheld device that can actually stimulate the area where the electrodes are overlying the baroreceptors, and they can have a change in the sympathovagal balance. I can envisage that if this therapy really stands the test of time and really works, one could certainly create a situation where you would try to have some stent with electrodes that could go there and mesh, just like a CardioMEMS device, which goes distally, but you can then stimulate that area with a handheld device. Obviously, we're looking way into the future, but that's a possibility that certainly exists. And it's exciting. It's exciting that we have something for acute heart failure that can enhance LV contractility. I think there'll be many uses for this in clinical practice.
And that's the beauty of EP. You can think of so many things. The technology is just evolving, to help our patients. This is such a beautiful pilot study, and kudos to everyone.
It's such an important field. So 5 million patients in the US suffer from heart failure. They're constantly being readmitted. We know that, you titrate people up, they look good, they go home and they come right back. And so it's really, this research in this area is just so important, because the magnitude of the problem is just unbelievable. So do you think that this is where we're going to make strides, at this intersection of EP and heart failure? This is where we're going to start having breakthroughs with these patients? Is this where we're going?
If that question is directed at me, I think that in acute heart failure, again, I think this is a therapy that could be very interesting, again, doing the acute hospitalization. It is not clear to me whether or not this will have any important durable effect in terms of, for example, changing rehospitalization. I think it will, but that requires, that requires data, and we'll see. I think that there are some very interesting electrical therapies. In my mind, neuromodulation is one of the most exciting areas. It's also one of the most complicated, because the variables are just so many. I think, Michael talked about, you can imagine the number of protocols, stimulation protocols, and ultimately, all the animal data with every one of those heart failure stimulation trials, the vagal stimulation trials, all the animal data was amazing. And then to get into patients, it's no longer amazing. Part of it may have to do with how you titrate and not being able to get high enough pacing, whatever. But these are not big companies that can afford $50 million trials for each stimulation protocol. So this is a very challenging area. But I still think that's where the Holy Grail is.
Another positive comment, though, is, as you mentioned, most of these are startup companies. The FDA has really done an about face, and the FDA has become much more supportive with some of their new algorithms and some of the new ways that they're both supporting and allowing approval, early approval of studies, and so on and so forth, to allow innovation. So there's a real opportunity that innovation is making a big comeback right now, which is fun for all of us who are sort of in the game. And I think more importantly, is going to be beneficial to patients, that we don't have to have these mega pivotal trials before anything can be approved. So good news, I think, for what we're going to see coming down the pipeline.
Great. Well, I think we're at the end of our hour. We're so grateful to Dr. Reddy. Your trial is innovative and exciting. And I really want to thank all of our panelists for sharing their expertise with us tonight. I'd like to thank Christina Stein for helping us organize all this and keeping everybody on track. And then Dr. Wang for his leadership and mentorship. So thank you all for being with us tonight.
Bye.
Again, thank you all for joining us.
Yeah.
I just want to send out a reminder, our next webinar on the device section side would be on July 21st. And I also want to highlight for the audience, the first 3 webinars that we've hosted thus far are now online on the AHA website, learn.heart.org. So feel free to go ahead and listen if you missed it in the past or want to just listen to it again. Again, thank you all for tonight, and hopefully we'll see you guys in future webinars.
Bye-bye.
Thank you. Good night, everyone.
Yeah.
Good night.